that there were some that showed that maybe they could do it under certain situations, but we learned otherwise. When you read the fine print, even in some articles that tout that the nurse practitioners were independent, they never were. So the truth is that there are no valid studies that show that nurse practitioners and physician assistants can practice safely or effectively when you remove physicians from the equation. So our argument is, if you're going to legislate and allow this independent practice, how can you do that ethically without knowing whether or not that practice is safe or effective? And we know from a study that was published in the Lancet a couple of years ago of countries of low to middle income that more people die worldwide from poor quality healthcare than those that die due to lack of access to healthcare. And that's because they're getting improper diagnoses or getting the wrong treatments. And so it's not okay just to say, well, we need more access. We need access to quality. And now we live in a world of evidence-based medicine, which there's not always evidence for everything. And sometimes we have to practice outside of that, but we should look to the evidence when it's possible to have it. And if there isn't evidence, well, where is it? We have all these states that have allowed independent practice, and yet I have seen absolutely no studies to show whether or not that practice has been of adequate quality.
And you know what? Here's one problem I will state. The last years made clear to us. I used to take it biblical as the New England Journal of Medicine and Lancet and the Journal of Vascular Surgery. That's another one that dealt with women and that. I took all those as biblical. Well, I don't anymore. I mean, when I'd read the article, I'd have a little bit of doubt. That's the whole point of being a physician.
You have to be skeptical all the time.
You got to have skepticism. But now, golly, I don't even know. And so that's us. We're having to police ourselves on that part. But
we do have to police ourselves. I mean, this is a profession. This is, we don't have a union. We don't have a big overseeing body. And we really do need to police ourselves, because when it becomes more about money than about patients, we have a big problem. And we need to make it really clear to the public, because the different larger, bodies that have controlled sort of the American Academy of Nurse Practitioners, even the AMA has had to back off on this idea of what they call scope creep. So then it's up to us to make it about patients, which is what it is about. If you start debating a physician versus a nurse practitioner versus a PA, it's not a versus situation. It's who can provide. Like, I probably shouldn't do vascular surgery, so I don't have the training to do that. And so it's the same piece of that what's best for patients. If I was out there touting this new vascular procedure, somebody should probably stop me. And that's what we're not doing, is we're sort of allowing people to say, well, all these studies show it's safe. And it's like, well, wait a second. Those are studies where physicians were supervising nurse practitioners and PAs. And people aren't being clear, and they aren't being transparent, and they aren't being fully honest with what's going on in the name of money. That's what we found. It's kind of,
and even more than just physician supervision, the other thing we found in these studies was that they always excluded high-risk patients every single time in these studies. In real life, you can't do that. You can't say, well, the nurse practitioner can see low-risk patients. Well, how do you know who is low risk?
They always excluded children as well. So even if it was like a GI clinic, all the kids were excluded as high risk. So how do you work in an urgent care?
So in our little world of wound care, here's a dirty little secret from the wound care world, and this applies to this discussion. About 20 years ago, we started to see the explosion of not just wound centers, but people starting to do wound care as almost like a hobby. And there would be these board, like weekend certification courses, and now they're going into facilities. And I'd say, whoa, now these people know enough to be dangerous, because it's not as simple as taking a scalpel blade to somebody. And I kind of see the same thing going on there. Rebecca, what your point is, when you've got this group of people who, they're medical, but have they put in their 10,000 hours? Have they really crafted their profession and the art of medicine? There's so much more to it. It's, the critical thinking, relying on experience too, as the great teacher in all this. The clinical hours are so important. So you can't fast track to an advanced degree, in my opinion. Now you know enough to be dangerous, potentially. So there's got to, over time, great, but you can't just have all these new grads, let's say, and just go right from one program to the next, and now they're in advanced. ARNP or FNP, or even going for the doctorate in nursing now too, which is becoming another issue that I'm seeing.
I'm so glad you mentioned the 10,000 hours because that's something that we write about in the book. And Niran, go ahead. You were going to say something about that.
Well, I was just going to basically say, 10,000 hours is the minimum really that I think any sport, it's been shown over and over again, swimming, tennis, chess, radiology, anything, to be an expert in anything. It's
Correct.
so important that you have that experience. And as a society, we undervalue experience. And I think that started, Rebecca and I are actually, while we're younger than you guys, we're still old enough to have done residency under the time when there were no hour limits, so we did our 36 hours every other day, and we lost sleep and we fell asleep at stop signs and all the things that I think go along with really becoming a physician. And we began to undervalue that experience. And what was great about those residency hours? What was great about it is you admitted a patient, you followed them for 36 hours, and then you took maybe a 12-hour break, you came back and you followed them again. So if they were septic, if they improved, if their vital signs changed, you saw everything that went on with that patient. And now there's no ownership in a way.
You learned something about the natural history of disease. Imagine that.
That's right.
Yeah, absolutely.
Vital.
I found too that if I had an experience like that, I saw a disease, and I dissociate it with a patient. And I might not see that again or that type of thing for a few years down the road. And then just like I just saw it 5 minutes ago, it would present in front of me and I'd have that recall because of that experience. And yeah, it's like it was Malcolm Gladwell's book where he really kind of illustrated that point that Niran, you just talked about. Whether you're an athlete, whether you're a musician, you've got to put in the time. And doing those long residency hours, we actually got into this discussion on a previous episode where we talked about how the younger residents now coming through, they're kind of putting demands on how little they're going to work. And I kind of hold to the point that they're kind of cheating themselves. In a sense, they're not being punished while they're going through the grueling hours. I look back on my residency, yeah, it was tough, it was long hours, but I got so much out of it. And the reality is I didn't have all the other headaches of my life that I do now. And I got to focus on being a doc and being a sponge and really, just immersing myself in it. And I loved it.